We're live. All righty. Okay, so first, what's the difference between examining a patient and evaluating a patient? Do any of you have kind of an idea of what that might be? And I'm going to be writing these things onto here. Oops, that's not the color I wanted. I wanted blue. All right, so why don't you guys tell me some things that if you're going to examine a patient, what would you do? Throw some things out there.
Observe.
Okay, you're observing. All right. What else? What kind of stuff do you do when you examine your patient?
Palpate.
Palpate. Okay, palpate. What else? What kind of tests would you do during your examination? Any ideas? Come on, I know you guys know this.
Standardized tests.
Standardized tests. Oh, look at you. Did you look ahead? Standardized tests. Okay, that's part of an exam. Yes. That it? Anybody gonna look at range of motion, or just forget it? Anyone? Yeah, you think that's a good idea? All right. So there's things like range of motion, right? The good old stuff, right? What else?
Manual muscle testing.
Okay, so manual muscle testing. What else?
Vision. Cognition.
Okay. Cognition. Ooh, spell vision. All right, so we're getting the gist of it. This is what we usually actually refer to as our evaluation, right? That's that 20 page thing we got to fill out and rocks every day. We call that an evaluation, but really the truth of the matter is all of that stuff is an exam. All of those are our exam items that lead to ultimately the evaluation. But what you need to understand is that all that stuff that's right here, all this stuff that we do, only becomes an evaluation once you add your interpretation of what those tests mean, and then they drive what you have to focus on in your treatment. And that differentiation was pointed out to me when I did my doctoral program. Because I always said, eval, assess, it's one and the same. But the truth is that's what delineates the difference really between the assistants and the therapists, is that they can observe and palpate and they can perform a standardized test. I mean, that's not rocket science. Everybody can press a stopwatch and do all that, right? You guys agree with me? It's what you do with that information and how you interpret it that is really the evaluation. And so the evaluation is exam stuff plus your interpretation. And so when you get to that assessment part at the end of that 20-page document you had to fill out and you're all burnt out, what you have to understand is that paragraph at the very end, the assessment and your impression, that's what makes it an evaluation. So think about what you put in there and don't just use the builds, because that actually is what is showing that you're actually thinking. And so if anything, that's where you should spend that 5 extra minutes and say, so what does it mean that, what am I going to do with the fact that they don't have range in a certain joint, or, so they don't have range. I mean, what does that reviewer care? Who cares? How does that, yes, Colleen, did you raise your hand?
Yeah, I just wanted you to know that Patrick just joined, so he has Jennifer and Tom with him. We're at a new OT and a new PT that we have at Huntington.
Welcome. Great. If you guys want to throw your webcam up, that would be awesome. And then I can see you as well. Let me send an invite there. Okay. So do you appreciate that difference there? I think you sometimes overlook that. Hey, Patrick, how you guys doing? So that is so critical. And I don't want you to underestimate the value of what you do with all of this exam information that we just listed here. Don't avoid that. Don't build it, because you can't build it, because depending on what the findings are and what the results are from the standardized measures, that is what you get paid for. That is what makes you a professional. So think about what you're going to put in there. All right, so we're going to use kind of a patient example and kind of walk through it. Now, I realize the majority of you were OTs in there, and like I said, I apologize ahead of time because I got PT on the brain. I've been it for 30 years. So, but you know, let's be interactive. Colleen, you can throw some stuff in here too. So this is our patient, pretty typical little lady, 85 years old, right, with a history of falls. We get that a lot, right? Her last fall resulted in this hip fracture with an ORIF. That's why she's seeing us. Pretty typical, right? She also has diabetes. She also has some Parkinson's. Pretty typical, would you say? We see a lot of that? A little bit of that, a little bit of this. That's why they come to us, right? Because they have all these multiple levels and comorbidities. Key is she lives alone. She lives in a single level home. We ask all these questions. This is just stuff you put in there, right? But it's important information. She has 2 steps into the home. That's going to matter because that's going to drive whether I'm going to really focus on steps or not. If it's a single level home, that may not be something I'm going to focus on. And her weight bearing status, of course, is important. Something that they frequently don't come over with, right? We're like, what's her weight bearing status? And then we're searching. Meanwhile, nobody knows. And then I think this is pretty critical. Prior to this fall, she did not use an assistive device. So that means this woman was pretty independent, probably a community elderly person who was operating fairly independently. She falls, and I don't know if you guys are aware of those statistics, but once an elderly person falls, are you guys aware of the statistics on a fall and if they have a hip fracture? You guys, yes, no? Do you want me to tell them to you? Mm-hmm. Yeah? Okay. So statistically, when somebody in this age group falls, 30% of them, 30, 33, never make it home. They stay in a skilled nursing facility. 33% or so die, and only 33% make it back home. So those are pretty devastating statistics. So obviously, as we all know, the best thing is don't break your hip. And prior to that would be don't fall, but everybody falls. Heck, I fall these days. But the point is that I don't break things yet. Once these people break things, they have a 33% chance of getting back home and getting to their prior functional level. And then we're going to talk about, when we get into the balance series, you'll see how things like fear of falling and other things just culminate the problem. So you now see this. This is somebody that was living independently just in this one little paragraph right here. You've learned all sorts of stuff about her, right? Is there anything else some of you want to pick out of there that maybe I didn't pick out? Anybody have anything to add? No? All right. So let's go on to the next one. Pretty straightforward. So now that I told you that about the lady, what kind of things would you in the room, all of you sitting there, what do you think you want to know? Now you're getting to this exam, these things. What are those things out of that list that we listed, or perhaps some things that we didn't list? What are some of those things that you are interested in finding out about? Now, based on that little paragraph. This isn't standard. This is this specific lady. She just came in. She's on your caseload.
Her balance. What's her balance like?
Okay, so you want to know what her balance is like. Okay, good. Because probably she didn't have the greatest balance, and that's maybe why she fell, right? That's kind of what you're thinking?
Yeah. Yeah, more specifics on how she fell.
How? Excellent. I agree. This is that detective part, because, right, if you don't find out exactly how, I mean, what if she told you that someone came in and shoved her over? I mean, that's that you approach it much differently than someone who just had a fall because they weren't paying attention. And then, or they say to you, I don't know, I just fell. I don't know what happened. You start thinking differently versus they say, oh, well, you know, I was stepping up over a step and my granddaughter was over and they left, you know, a slinky or something on the stairs. I stepped on it. I thought it was a snake. It scared me. I jumped and I fell. So you're like, okay, so that was probably an appropriate response versus, I don't know. Or I don't know. I got up and I got dizzy and then I fell. Have you heard that?
Mhm.
So that's that how part that sometimes I think we don't spend enough time asking and doing that detective work and really drilling down and saying and asking specific questions, kind of what we refer to as leading questions. You've learned about those in school, right? First, you're supposed to ask the subjective and just listen, and then you have some leading questions, which then they can say yes or no to, because they'll overlook certain things. And I always ask the dizzy one, and I'm going to add that to the list here. So we had how did you fall? I'm going to want to know, did they experience or do they experience any dizziness? And we'll talk about that when we get into the balance series on the importance of that. 78% of elderly that have experienced a fall, 78% have BPPV, benign paroxysmal positional vertigo, which is easily treatable by us. We don't ask. We just overlooked one huge cause of the fall, and we could be treating their range and their strength and doing, the bike and doing all this fancy stuff. But the truth of the matter is they have BPPV, and if we didn't address it because we didn't ask, then we're not doing what we were supposed to be doing for the patient, which is treating the underlying cause of a fall. So again, the how piece is very important for you guys to ask. Okay, what else? And we're going to get into later, you're like, well, I wouldn't even know what to ask for B. I don't expect you to know that right now. We'll learn about that later. But these are just kind of prompting kind of questions for you. So what else? We said balance. We said dizzy.
Sensation.
Excuse me?
Sensation, neuropathy.
Right. Good. So sensation. You want to know whether she even feels her feet, right? She has diabetes, so you're already kind of going, Good question. Good thing. You're going to want to test for that, right? You may not test for that in somebody that's younger and doesn't have diabetes. You may be able to overlook that. So what I'm trying to get you guys to do is to drive your eval because you don't have a lot of time. None of us do. And so by starting with certain standardized measures and starting with the bigger picture, you can then drill certain directions on your eval and say, I really need to do a really good sensory eval on this woman because she has diabetes and she fell. But let's say she has, she's younger and she doesn't have diabetes. I may not have to spend that much time there. So what I'm trying to explain to you is that you don't always have to go, I know we have to fill in most things in eval, but as a therapist and a thinker, you may say, I don't need to worry about a specific area because I have this critical thinking and I need to spend a lot more time on the balance area. And then we're going to talk about a whole lot about balance in the next modules on how you were going to pick that piece apart. Because balance is a very complex thing, as you all know. All right. So anything else? Does anybody care about whether this woman can even see?
Vision.
Yeah, right, OTs? Right, vision? How many of you OTs in the room have some kind of vision background or vision training from school? I know you guys mostly are new grads, but I know OT spends a lot of time on low vision. And that's something I can't do a whole lot of training on, but can I see like a show of hands? I mean, do you guys feel comfortable with even looking at that? Okay, I saw a hand coming in from the side. All right, so there's some background there, right, OTs?
Mm-hmm. Yes.
Okay. Do you use it or you don't have time because you're busy filling out a whole bunch of other stuff?
I do a general vision assessment, but I think a lot of times like you have to figure out what the home environment looks like to assess what their vision is like at home, because that lighting and all the other components really play into it, especially for a certain age group. Like they only use lamps and things like that at home.
I think that's all really good points. And where in your eval are you going to put that information? Because the exam portion of the ROX eval, does it spend a whole lot on vision? Do we have an area for that where you could elaborate on that?
Yeah, but it just says like within functional limits, reading glasses,
it has just a quick little couple check boxes. Then there is you can fill it in. Yeah, there's a comment section where you could fill in more specifics.
And okay, so this is all honest. This is transparent. This is the world we live in, right? Transparency. So go ahead and admit to me and your colleagues, how many of you OTs have elaborated in that little vision section more than within functional limits, or yes, they wear glasses, or no, they don't?
I would if one eye is more affected than the other, and like specify, like, you know, right vision is greater than left eye vision, or glaucoma, macular. You know, you would kind of write in a little bit more specific as the diagnosis, not so much. Yeah, like testing wise, not so much, but more of a diagnosis.
Okay, all right, and that's good. I'm happy to hear that. And then the next step is, what do you do with that information? So let's say you find out about this lady, she has glaucoma, and she has she has cataracts, and she actually wears corrective lenses with prisms, and she left them at home. Are we going to do anything about that, or do we ask those questions? Because again, I'm not saying you do this specifically, but what I find is that area tends to be ignored, and then if let's say you did ask the questions in the eval, which hopefully all of the OTs are doing, then what do we do with the fact that she doesn't have her glasses and she needs better light? Do we actually change the environment in the room that she's in? Do we address that environment? Are we making those changes? And I'm not saying you do or you don't. I'm just saying these are those things that we, as part of treatment, yes, whoever's over in the corner there that I didn't see said that a lot of the visual assessment will depend on their home environment, because they only use lamps. You know, they're in small little cave-like apartments that are kind of dank, and they may not have great light anyways. So those are those kind of things, but what do we do about the environment that's here as well? So just food for thought. All right, so that's good. That's good. So we covered some stuff. So let's look at how did she fall? That obviously is coming from the interview, right? And why? I can't emphasize how much time you need to spend on this. I find that that is very, very critical. And then when you find something like an aha moment, you need to continue drilling that way. So what about her confidence and her balance? So are any of you familiar with balance confidence measures? Not actual Berg and those kind of things yet. That comes in how you measure fall risk. But anybody heard of a ABC scale, activities, balance, confidence scale? Okay, so I see somebody nodding their head. How about a falls efficacy scale? Have you heard of that?
Yeah.
Okay, so those are two scales that once we get into the meat of the balance portion of our webinars, and when I'm there, I'll bring you guys a notebook, kind of a resource book that you'll have this kind of stuff. All of this is available on Rehab Central for you to download. But again, not for you to necessarily do this today. This is to stir up the embers and kind of get your little wheels turning so that we can move from there. But those two scales are the best right now in measuring standardized tests with norms and cut scores for balance confidence. Actually can be translated into G-code scores as well, and are very valid for that. And balance confidence is one of the top, or fear of falling is one of the top risk factors for repeat falls. So, and as you know, I don't have to tell you this, once somebody falls, then they're afraid, especially if they broke something. So breaking that pattern, specifically addressing fear of falling, which is a confidence building thing, making that part of your treatment plan then becomes imperative as well, and addressing it specifically for that reason. And how you measure it is you would remeasure that balance confidence score, whichever test you chose to use, and then you can show % improvement because your treatment is specifically targeting improving their confidence. And how you get there, I'm not going to tell you that specifically, but you're all good thinkers, you've learned about this, but my point is in this little piece is you actually have something that says that this is where their impairment was when I saw them first. As far as their confidence, we've been working on improving their confidence in these different activities that are specifically designed for that. and then you remeasure it at, you know, the 10th visit or whatever that frequency is, and then you're going to say, wow, they actually made an improvement. And we'll talk about what improvement means and how that looks in just a few slides. So let's go back to, let me get my cursor back on here. Sorry. Okay, so balance measures of fall risk, right? Everybody knows about the good old Tug, Berg, Tinetti, functional reach. Those are all ringing a bell, correct? Everybody's like, yeah. Okay, so what we're going to do is talk about, we'll make this a real life example, and then we'll talk about how that might look in this case of this patient. There's all sorts of fall risk measures that we have available to us. You get to decide as a clinician which one is most appropriate for that patient. There's some go-tos that you're always going to love to use, and it will probably be useful for most patients. But what I want you to understand is that when we have somebody come to us with a fall, I don't know how many evaluations I have actually read when I see exactly that little paragraph, patient fell, they had a hip fracture, and nowhere in the assessment and the evaluation do we have an actual objective measure of fall risk. We can't have that happen. We have to actually objectify how bad is that risk, because then as we do our treatment interventions, we'll be able to remeasure against that. So we'll talk about, you know, choosing one and how we're going to move forward with that. Okay, here I'm not going to spend a lot of time, but the actual balance test specifics, this means limits of stability, reactive postural control, anticipatory postural control. Does any of those ring a bell to any of you? Does that sound like something you've heard about before?
Yeah.
Probably somewhere in school, right? And then you probably haven't used it a whole lot. Well, the thing is, this is our world, folks. We're supposed to be fixing these people's fall risk, and we're going to need to be drilling into how we're going to specifically evaluate each one of these areas. And the biomechanical areas, which that's what most therapists are the best at. But this is a place, there was a study I just read in the Journal of Neurological PT, and they said that the one place therapists by far, it was a systematic review, fall short in evaluating balance, OTs and PTs, is we don't look at reactive postural control. And when do most falls happen? When you get hit by something that you weren't anticipating and you have to react. Yet we are not training to reactive postural control because A, we don't even know how to assess it. And then if we assessed it, we go, oh, wow, that's pretty bad. And then we don't address it in our treatment. So we'll be talking about that in the balance modules as well. Anybody heard about attention allocation deficits? No. Okay. So this is a huge area, and Shumway Cook started this back in 1997 talking about this. So it's been around a while, pushing on 20 years. And it was kind of groundbreaking then, but the truth of the matter is a majority of our patients that fall elderly, the question is, can they dual task or multitask, which happens at home, right? They're walking from point A to point B, and they're trying to carry their coffee, and they're thinking, you know, about balancing their paper, and then they want to make it to their chair so they can sit down and have their coffee and their paper, and then the phone rings. And boom, they fall. And so even though they may pass all of our standard fall risk measures and balance may look good on some basic tests, we need to go to that next level, drill just a little bit lower if they pass everything else, and say, do they have attention allocation deficits? We'll talk about how you test for that and then how you would treat for that. Okay? And so that's referred to as dual task cost of an activity. And that's something that we need to be really good at. And that's language that you can then use, which not only makes you sound really smart, but actually makes you sound really skilled. Because that's what we are. We're supposed to be skilled people. So we should be knowing what sets us apart from yourself, the tech out there, or the RCS who's working with the patient, or the RNA. Okay, we talked about dizzy. We'll spend more time on that. We talked about vision deficits. All right, so We talked about the in-depth interview. We talked about the functional FVS scale, ABC scale. We talked about fall risk. We'll look at that in a bit. Limits of stability, reactive postural control, anticipatory postural control, coming in your next few sessions. Attention allocation, how you would test for that. There's a thing called a cognitive tug, and there's a thing called a walk and talk test. So there's actual standardized tests out there to look for it. How do I measure dizzy? I might use a Dix-Hallpike test, that's what that is, or a dynamic visual acuity. Not going to spend time on that right now, but again, standardized tests. And vision deficits, we're going to talk about acuity, macular degeneration, cataracts, and are there any standardized tests? Again, I'm not an OT, but maybe there's some things you're going to add to that list. And so what do I do, and what's the direction that we're going as a profession or professions, is that you're going to come in, see a patient, and you're going to read that little blurb, and you're going to whip out a few standardized tests to address balance, to address fall risk, to address attention allocation, to address dizzy, to address vision or whatever, or cognition. And if those tests, they pass them, you go, oh, I don't have to spend so much time there. They fail one, you're like, oh, I got to do a little more, I got a little more work there. I'm gonna drill in. So you see how that, instead of doing all the range and the manual muscle testing and sensation first, you come in, you do your standardized measure, you go, I have a problem, I don't have a problem. I have a problem, I'm going to spend a lot of time and start expanding there, as opposed to I don't have a problem in cognition, I don't need to spend a lot of time there. So you see how this goes? So it's like the pyramid's now inverted, okay? We used to start, let me see, I don't know how I can do that on here. So you get what I'm saying, is you start, we used to start really big at the top. I guess I would do it upside down, and do all that stuff, and then kind of drill to the top. Now you're going to come in from the bottom, and you're going to hit them with the standardized measures, and you're going to know where you need to focus. And you're going to end up having a better eval. Because in the end, that's the assessment piece that you need to look at, and the interpretation of it. All right, so in this lady's case, let's say I'm going to pick some tests. Okay, and I'm just, again, some of these may not make a lot of sense to you yet. I'm sure all of you are familiar with the Berg, correct? Everybody's familiar with the Berg, you've seen it, you've used it probably a few times, yes, no? I'm looking at you guys, can I see some nods? Yeah. Okay, all right. So the two people at Broomall that are in the screen, you guys are on target. The rest of you are all hiding from me off screen, but they're taking it for the team there. So you guys got a nod for them. Yes, no. All right.
We'll realize for them all. Yeah. We don't know how loud to be.
I can actually hear you guys just great, so it's perfect. Okay, so everybody's familiar with the tug, right?
Yes.
Mm-hmm.
So why would I maybe choose these for this lady? Any ideas? Because remember, I just saw her, I read that little blurb, and I'm going to do a Berg, I'm going to do a tug. Is it just because I decided to do those and I happen to have those in the file cabinet?
Hopefully not.
Right, hopefully not, but sometimes that might be the decision. I'll tell you why I'm going to do the tug. I'm going to do the tug because it has great values for Parkinson's. It takes me no time at all. It's easy. And it has huge value and a lot of normative data, predictability. It has MDCs, which we'll talk about in a second. The Berg, you don't know this yet, but you will after you get through the balance modules, also has a reactive postural component to it, which the tug does not. It looks at bending over, it looks at stepping up. It's a little more of an extensive balance test, and it's very, very valid in this population. And then I'm going to also do a mini best, because the mini best actually covers 5 domains of balance. We're going to talk about domains of balance in one shot, and she's a higher level patient, so she'll probably be able to do that test. It's a higher level test. It won't be appropriate for a lot of our patients, but I have 3 balance measures that are going to give me fall risk, and it's going to cover all the 5 domains of balance. Maybe the OTs want to do a functional reach. And there's nothing wrong with doing more than that. What's the 5 times sit to stand? Anybody heard about that?
Yeah.
Okay, so what happens during that test? You ask them to stand up 5 times and sit down, right?
Yes.
Mm-hmm.
Pretty simple. Doesn't take a lot of time, and you measure the time, and based on how long it takes them, it will give you whether they're a fall risk or not. But what else does that test address that a lot of other tests may not? This addresses something that the Tinetti does not really address as well, and the Berg. Any ideas? If I'm going to have a hard time standing up, I'm trying to get up, what might you think be the reason I can't get up without using my hands?
Leg weakness.
Okay, so it addresses, it's a great test for strength. And it also tests what? Let's say you have strength, but you don't have what in your ankles?
Range of motion.
You don't have dorsiflexion range of motion, which a lot of our patients don't have. And now I know based on that test that I better look at her dorsiflexion range of motion, because if she's having a hard time getting up and she's got quads of steel, I'm like, why can't she get up? Well, maybe she's got plantar flexion contractures. I just decided based on that what impairment to drill down to from a standardized test. Do you see how this is working? So from these tests, these drive me a certain direction. So why might I do a 6-minute walk on her?
Is she in the corner? Activity tolerance. What's corner?
Exactly. Activity tolerance, great endurance test, has great predictability for rehospitalization, great normative values. Maybe she can't do 6 minutes. What else could I do in a walk test that might measure? Have you heard of the 2-minute walk test? Also standardized. So I'm going to clip out of this for just a second, and I'm going, well, let's add one more thing here. So what does that stand for?
You can't really see it.
Maybe I can lower this. If we can minimize that.
Velocity.
Yes. Woohoo! Excellent. Who said that?
What did you say?
Patrick.
Gait velocity. Way to go, Patrick. Gait velocity. Woo! Very, very, very important. I can't tell you how important gait velocity is. So we're going to spend some time on this. Okay, OTs, bear with me. But the point is that one little number has more prognostic and predictive value than any of the other tests out there. So we have to measure gait velocity on anybody that's ambulatory. I don't care if they only walk 20 feet. You're going to need to come up with a gait velocity. So we'll talk about how you do that, because that's going to tell you a lot about whether this person's going to die. 8-year mortality has been predictive because of gait velocity. That's why I tell everybody I'm working on my gait speed now, because I don't want to die. That was a joke, okay? So the point is that if you walk slow, you're in trouble. And the slower you walk, the more trouble you're in. So remember what I told you at the beginning? Those people that fell and broke a hip, only 30% of them are going to make it home. Gait velocity is going to tell you who those people are going to be. So you're going to need to work on speeding them up. So I don't think that we originally appreciated the value of that. If you're not walking fast enough, you know, everybody focuses on distance, you know, 150 feet. Well, who came up with that? When did that become like the gold standard for you're going to do really well if you walk 150 feet? The point is now the evidence, the research has shown us you can walk 150 feet, you can walk 500 feet. You don't walk it fast enough, you're in trouble. And so we'll look at those. I'm going to jump out right now real quick, and I'm going to show you some documents that we have on Rehab Central. And I'm going to show you this. Have you guys seen this chart? Do you have this in your facility printed off, hanging, laminated somewhere? Okay, if you don't, you need to go to Rehab Central, print it off, and have it. Because PTs, once you get your gait velocity, and I'll show you how to calculate that in a second, here are all of your normative values for gait velocity. We'll talk about MDCs and MCIDs in a second. 6-minute walk test norms. You absolutely, this is a super valuable piece. It takes you literally 10 seconds to get this number. And then it gives you all sorts of information. So let's take it a step further. What does that one number tell you? Wow, look at this. Have you seen this? This is on Rehab Central as well. So I don't know if I'll enlarge it a bit. So remember, let's say you take the measurement. We'll talk about how you do this. Let's say your patient's walking at 0.2 meters per second, right here. You see that? So let's look at 0.2 meters per second, and where does that, oh, what did I just do? Where does that take us here? Household walker, you're like, okay, well, whatever. Look at this, mortality, mobility, ADL disability at 2 years post, increased assistive device use at 7 years, 2 times the probability of frailty if they're over 75 years of age. All that from one number? Holy moly, to me that's pretty valuable. It didn't take me a whole lot. Look at this. Risk of death and hospitalization and falls if you're in this 0.2 to 0.6 category. So do you see, I'm not just saying let's do gait velocities because it's just like, you know, I think it's really kind of cool to do some math. What I'm trying to explain to you is the value of something. And so OTs, I challenge you to ask the PTs in your department that aren't here in this lecture right now and say, hey, did you get a gait velocity on them? Because I kind of want to know what their prognosis might be. And they're going to go, what? And you're going to say, well, you know, you need to look it up or find out or talk to Colleen or call Andrea because we need to get a gait velocity on these people. It tells us a lot about where they're going to be. It tells us a lot about how they're going to perform. It tells us what we need to be focusing on. So I can't emphasize that enough. All right. So let me see while I'm out. Now, I'm just going to show you this next one because I want to stay in the PowerPoint. This is also on Rehab Central, balanced tests for fall risk, cut scores, MDCs, and MCIDs. We'll talk about these two things in a second. So if you chose to do the Berg on this person, here's your cut score for fall risk. So I took all of these off of rehab measures, put them all in one table. It's like a 4 or 5 page document, 3-page document. There's 2 pages. So here you have your cut scores. Here you would have if they improved, the amount of change that they have. What does that mean? She has Parkinson's. She's also an elderly. So if you had a point difference of 5 in a retest, that's a meaningful detectable change. That's what that sounds for. That's what that stands for, MDC. So again, being super objective, and you can then say, wow, I'm really making a difference because I made an MDC change in that 10 days. If you're not making an MDC change, you have to look in the mirror and go, what do I need to do differently? Am I really being as specific as I need to be? Am I being hard enough? Am I focusing on what I need to focus on? So this is how you always come back around and check yourself. All right, so these are just, again, some resources that are available for you, but I'm going to, and these are all on Rehab Central under the balance pieces. Okay, so let's go back to the PowerPoint. All right. So why do you want to use a standardized measure? Any input there other than Andrea said so?
To measure progress.
Okay, so we want to measure progress. Oh, look at that. I already put my stuff right there. Let me go back here. You're right, to measure progress, highlighter, ink color. So we want to measure our progress. Can you see the yellow?
Yes.
All right, you definitely want to measure progress, and we want to measure it objectively, right? Any other reasons why you might want to use a standardized measure?
For consistency.
Okay, good. Consistency. That's also referred to as inter-rater reliability, right? That's a fancy word for that. What about the people that pay us? Do you think they're going to like standardized measures other than you just saying, wow, Mrs. Jones is doing so much better? Woohoo. Do they pay us for that?
No.
No. But when you have a standardized measure to back up your improvement or your claim to improvement, guess what? They need to pay you, and if they don't, then those of us that have to go, and Stacy in the end, that has to go up against the administrative law judge to say we need to be paid for this. If she has that ammo, if she has that scoring, she shows it to the judge, and they're like, well, of course you got to get paid. You guys have made an impressive difference based on these standardized objective measures. But if we don't use them and we're just like, well, their balance is really bad, and whoa, you know, they're doing so much better. Their balance is better. It's a lot better. Do you see what I'm saying? And I can tell you that the one thing that we have on rocks, unfortunately, and we're working on changing this, it doesn't happen overnight with rocks, the Kansas, which comes up automatically, but now rocks has some other measures for you to choose from. Choose the other ones. Don't use the Kansas, because the Kansas is not reliable. It's not objective. Okay? It does not have cut scores. It does not have MCDs and MDCs associated with it, MCIDs. It doesn't do any of these things, and that's what you're looking for. So let's say you go to a class or you've read up on a new measure, and you're like, wow, this looks like this would really be good for our patient population. And it's not on the list that is on Rehab Central, that list that Andrea showed us. It's okay. You can still use it as long as it meets certain criteria. My recommendation to you, OTs and PTs, is I would go to rehabmeasures.org, which is a website that it's called rehabmeasures.org, and you can look up any standardized measure. And if it's not on there, you probably shouldn't be using it. And if it's on there, you need to go to the instrument review, and then you can ask yourself, what's the reliability? And you can look at these things. But we did a lot of that work for you already, and I try to keep that updated. But for example, I had a couple of people that called me with the function and sitting test, because there's not a lot of really great tests for sitting balance. And I had some OTs say, hey, did you hear of this? I said, well, as a matter of fact, I did. I'm reviewing it right now. And then I went to a seminar on it in California at the APTA conference. And now that is on our recommended list. It's probably one of your better measures. So it is changing. None of this is stagnant. So what I'm saying is go ahead, be free and explore, but just be a critical thinker. That's what we would expect, actually, for you to say, hey, I found something. All right. So let's say we go back to our little lady, and she scored a tug of 18 seconds. Well, this number right here, 13.5, based on the little sheet that I showed you, that's a cut score for fall risk for her. Okay? So that tells us she's a fall risk, right? Because she's walking slower than the 13.5. I do a gait velocity measurement on her, and she's at 0.4 meters per second. Well, remember that chart I showed you on Rehab Central, 0.4 meters per second? We'll talk about that in a couple of slides. But you remember that's not a good category to be in. That's like a danger Will Robinson category. We need to really focus on trying to speed her up. She did a cognitive tug, which you don't know how to do yet, but anytime there's a 10% difference between a tug and a cognitive tug, that shows us that we have a attention allocation deficit. So now I know that I'm going to be focusing on that in my treatment. Her 5 times sit to stand was 20 seconds. If I look that on the sheet, the cut score for that is 15 seconds. So she's a fall risk there. I did a mini best on her just because I'm an overachiever. And she scored 15. And so for Parkinson's disease, an elderly, a score of 20 or less indicates a fall risk. And primarily because the beauty of the mini best test, again, I'm not telling you that this is everything you do for everybody. This is this one specific patient. This really measures reactive postural control that a lot of other standardized tests don't. That's why I chose it. It also looks at dual tasking, so I may not have had to do a cognitive tug because actually a cognitive tug is part of the mini best. And it looks at strength and range of motion as part of the testing. So with that one test, I could have done that one test and gotten rid of all of these, actually, because it addresses all of them. But I'm just kind of showing you that you can pick and choose how you want. And then I did a 6-minute walk on her, and she went 200 meters. The norm for her would be 392. And so now you see I did tests. I got numbers. I can actually standardize where she is. And now I know where I want to go with my treatment and where I'm going to want to focus on my assessments really close. So the gait velocity G-code document I just showed you It shows on that gait velocity document before, and this is the link right here on Rehab Central that would take you to that specific document. All right, so some of you, now where are my PTs in the crowd? I need your faces on the screen. There's a PT. How about another PT? Okay, great. So it's okay, we're just all family here. Can we, do you know how to measure gait velocity? You do?
Yeah.
Okay, great, great. So anybody else want me to show you how to measure it?
Yeah.
Sure.
Okay. So basically, you're going to take a certain distance. That can be whatever distance you want. The 10 meters is standard. Okay. Patient starts walking over here. Here's our patient. Not right at the line, before the line. And they'll start walking, boop, 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 and you'll start the timer here, and you'll start the stop the timer there, and you're going to tell them to keep walking. So your sample area that you took them in is part of the whole runway. So in a true 10-meter walk test, what they recommend is that the patient starts here at 10, and then you sample the middle 6 meters. What I do is I take 5 meters, and I have a runway before and a runway after. You can do it any way you want because all it is math. Okay? It's meters per second. All right? So as long as you know the distance of your sample area, whether that be 3 meters, 5 meters, 10 meters, 6 meters, doesn't matter. Okay? So let's say, hold on a second. Let's say Mrs. Jones here, the little lady we had, she went the 10 meters. I'm going to use the full 10 meters on her. Okay? So she went 10 meters in 6 seconds. That's going to equal 0.6 meters per second. Do you see how that works? It's that simple. So you can, whatever the meter distance is, 5 meters in 6 seconds, you would divide 6 into 5. Whatever that ends up being, it's probably going to be twice as much, right? 5 meters less speed. What's the math on that? Somebody give me a calculator. So that's going to be double that, right? So she's twice as slow. So she's 0.12 meters per second there. Forget that. I got to erase that there. Look at that. Isn't that fun? All right. Highlighter. So that would be like 0.12 meters per second. How do I know that? Well, she went 10 meters in 6 seconds, and the next patient comes along and only does 5 meters in 6 seconds. That's obviously way slow. It's a lot slower. So you see, now I've got these numbers that then I take and I compare against all of those charts. Okay, so does everybody see? It's pretty simple. It kind of messes people up, but it's pretty simple. All right? Okay, so let's look at this. Remember I talked about cut scores, and then we talked about that chart that we had earlier. So these are just some general values. If a patient's walking less than 0.4 meters per second, that would put them in that household ambulator category, but there's a lot more that goes along with that value. If you look on that G-code calculator sheet, there's limited community ambulation right in between, and then 0.8, greater than 0.8 is in 0.1 really is 1.0 is really what you're pushing for, but that would put them in this community ambulator level and gives you better prognostic value. A lot of our people don't even scratch the surface coming, they're stuck down here. So we need to be focusing on that. So what's an MDC? Remember I talked about minimum detectable change. So it just so happens that for gait velocity, 0.17 meters per second happens to be the magic value for a meaningful change in gait velocity. So when they came in, they were walking at 2 meters. She was walking at 2.2 meters per second. And at week 2, she's now walking at 0.54 meters per second. Okay? So what's that difference right here? If I subtract 0.2 from this, right, is what? 0.34, right? and the MDC is 0.17, so she just met a meaningful detectable change in 2 weeks. Congratulations, woohoo, fireworks, confetti, way to go. You need to write that in your documentation to show that what you're doing is making a meaningful difference. So don't overlook it, use it to your benefit, okay? Do you see how where this is going? And you can do this with any of your test results, any of your standardized measures when you check it against an MDC, whether that be a BERT, a functional reach. And if you didn't meet it, then you again have to look in the mirror, put a mirror up in your gym and look at it and say, what can I do differently to change this? Because I need to be making more change. Okay? So everybody kind of see how that works? Is that pretty self-explanatory? So you have that number, and then if you meet it, awesome. If you don't, just say, hey, got to change it up. Now you say, well, Andrea, I mean, how much time do I give myself to meet this? Well, that's a good question. These are not tied to time right now, but I would say that if I'm not approaching a meaningful detectable change in certain tests that I looked at, in 10 days, I would factor in comorbidities, how sick the person is, how much they attended therapy, what their activity tolerance is, and then I might give myself a little more time. If they've attended all the therapy and they're all gung-ho and they're not meeting it, then I have to say, maybe I need to up my game. Maybe we need to make therapy a little more intense. So again, it's not an absolute value that's tied to time, but you need to be asking yourself that question. Okay? So for example, an MCID, this is actually incorrect. This slide was written by somebody else. I'm going to fix that. It's really, these are MDCs for geriatric patients. You have a small MDC, which is 0.05. So see, they're already starting to add smaller ones for that shorter period of time. So in the case of our population, meeting a small MDC of 0.05, which is not all that hard, says something. You need to brag about it. And or 0.13 meters per second, which is a bigger change. Again, use the numbers to your advantage. And as you start using these, and as you start, they kind of become second nature to you. I load a bunch of these on my phone. And then I have them there, and then I know how to look real quickly as references. That's just how I do it, because I'm all about efficiency. All right, so how do we measure progress? So you come to that 10-day, maybe every 30 days. You're going to use those values, and then, you know, we talk about doing our short-term goals and impairments, and that's how our documentation is still set up. In the end, if you aren't bringing yourself full circle and back around to some of those tests that you originally looked at and saying, how do I measure up? How does my plan of care measure up? Are we making the changes? Then you don't have any meat to what you're doing. And so the fact that somebody improved a manual muscle test score on a certain muscle, let's say it's their quad, or let's say it's their shoulder flexion from a 3 to a 3+, big deal. I mean, what does that mean? And so we're always saying and pushing you guys to tie it to function. But take it a step further, tie it to function, but then tie it to an objective test that can measure that function that says, and they happen to increase in their strength and this and this and this, and that is demonstrated or evidenced by an improvement in this objective standardized measure score, as you can see. So again, I'm always coming back around and saying, let's use those scores. All right. Now, let's say your retest shows something and it doesn't show what you wanted. Let's say only one of them shows a change. Let's say she has no change in gait velocity. She has, you did a 5-time sit to stand, remember in the beginning? She has no change there. You're like, ooh, that's not looking so good. Okay, she got a minimal change in your tug. So you're like, okay, I got something here. So you're going to go, is that enough? Is that enough? Oh, it's only 1 second. Well, if you look up an MDC on a tug, that's not enough for an MDC, and they don't have a small one there. And she's still requiring some assistance. And let's say this was done at a 10-day. And she made a big change in her 6-minute walk. She actually changed by about 40 meters. So if you look that one up, you'll see that about 56 meters is a really impactful value. So does that mean that 40 is useless? No. You can speak to that. You can say that an MDC is 56, but she's increased in her endurance, but her actual gait velocity may not have increased. Her strength is getting there. Maybe it was 20 seconds before, and now it's taking her 16 seconds, and you happen to know that a cut score is 15. I would speak to all of those things. Even though she didn't meet it, it's not the end of the world, but talk about, is she close? Is she getting there? How much further do we have to go? What comorbidities? Maybe she had a fever. Talk about that stuff. Bring it back around to the objective stuff, okay? All right, and then I'm going to bring it right back to you, to that mirror, and I'm going to ask you if people, and when I come to visit you guys, I'm going to ask you these questions. Is the exercise intense enough? What's the frequency? I'm not saying does she come in, 5 days a week or whatever. What's the frequency of the independent exercise? What's the dosing that we're delivering? The research, Tiffany Schubert did a recent article on balance in geriatrics, and they're starting to now come up with prescriptive dosing on how much you need to actually make a difference. And so that's the direction we're going. And she happened to come up with 50 hours of actual balance training for community-based elderly to actually make a difference, a meaningful, detectable change in their balance and these different balance measures. So we have to ask ourselves, we have such sick people that are in our facilities. But I have to tell you from personal experience, as I'm out there, yeah, they're sick, but they actually can handle a lot more than we think they can handle. And I have therapists walking and doing stuff with the patients, whether that be an activity function, and they're always asking them, do you need to rest? Do you need to rest? Do you need to rest? Why don't we wait for them to say, I need to rest? Or is it the therapist that wants to rest? That's my question. Are you the one that wants to sit down? So there was another study done in an outpatient setting. This was about 4 years ago. And they had these, I think they were PT students sitting in there, and they were looking at gait, and they were looking at OT treatments in an outpatient clinic. And they were looking at how many steps, that's just what I'm going to bring up for you right now, just to bring this home, but the same thing is the amount of time spent on a functional activity, what the OTs were doing in functional activity. In the hour treatment that outpatient was there, and this is an outpatient who has supposedly better activity tolerance, in the hour that they were there, they spent, the patients walked 237 steps in an hour. And they're there for gait training and PT. And then in OT, they spent about 30% of their time on the functional activities that they were supposed to be doing. So 237 steps. Do you guys have any idea how many steps the average stroke patient takes once they go back home into the community that they're walking? It's in between 4,000 and 6,000 steps a day. And they're coming to therapy 3 times a week, and we're walking them 237 steps? Really? Are we going to be making a difference? I don't think so. So after I read all that research and I started looking at that as a PT, I'm like, I'm not walking these people long enough, fast enough, hard enough. And I want you to ask yourself that. Now, I'm not telling you guys to go out into the clinic right now and drive everybody into the ground and then all of a sudden everybody crashes, medically. That's left up to your clinical judgment. But I want you to ask yourself that question. Could I have pushed them a little further? Could I have asked for a few more reps? Could I put more weight on them? Can I do this for a little bit longer? Can I make them walk a little faster? Can I stress them a little bit more? Am I holding on to them too much? These are all those kind of things you have to ask yourself. And as we move through the balance seminar series, you will see more and more evidence supporting that we do way too much for our people, and we aren't working them hard enough, long enough, and we certainly aren't walking them fast enough. And so how do you get there? That frequency piece, let's say you have that very deconditioned patient. And Andrea just said, I need to walk them faster and further. But they can only walk 20 feet at a time. So is that what you do? You walk them 20 feet 3 times and you're like, we're good. No, you're going to walk them 20 feet and then they get to rest, and then you're going to do something during that rest, and then they're going to walk 20 feet again, and then you're going to do something else, and then they're going to walk 20 feet again. And are you going to sit them back into their wheelchair? No, you're going to get them up out of their wheelchair and they're going to sit on the edge of the mat. Maybe the rest on the edge of the mat is they're working on trunk control. Get them out of the chairs, people. Get them out of the wheelchairs. Park the wheelchairs somewhere else. We're starting a new program, company-wide, called the Park and Go program, which is once these people enter, and I'm not saying you need this today or tomorrow, but again, we're pushing for this, is that the rehab gym is a place you work out. And so patients need to know that, you know, go out in the gym this afternoon and see how many people are working out of their wheelchairs. Because I'm going to ask you that when I come there too. And I'm going to say, why are they in their wheelchair? Why can't they sit in a chair? Why can't they sit on the edge of the mat? Why can't they sit on a different sitting surface? Because even that rest then isn't rest. They're working on their trunk. So you guys are following me, right? You see what I'm talking about? There's a lot more we can do, but we've gotten complacent over time. And we need to push harder because we need to get outcomes faster. And one of your sister facilities in your region has got their feet held to the fire because of a new reimbursement, Navi Health, and they're saying their outcomes aren't as good and in as many days as other people's. So, you know, they're looking, they're watching, and we have to say, based on the evidence, this is, I'm pushing them this hard. So again, look in that mirror and say, can I do that better? And then specificity of the exercise. Okay, there's a thing called task specificity. I didn't make the word up. I'm sure you've heard of it. And that's where all that functional strengthening exercises happens. And the task-specific exercises. So, to water it all down, if you want to walk faster, you don't work on bridging on the mat. And you don't do short arc quads. Guess what you do? You walk them. And you walk them a lot. And you walk them fast, and you walk them in different environments with maybe different assist devices. If you want to improve toilet transfers, what do? You work on toilet transfers. Do you do it once and say, that was good, Mrs. Jones? Or do you do it different directions, different series, you know, the repetition, frequency, interval training, that whole concept? It works for any activity. But I can't emphasize task specificity enough, because all of the motor control research is coming back, whether that's a neurologically damaged person or whether that's a normal nervous system. All of it's coming back saying, if you don't work on the actual activity, they're not going to get better at that activity. And so you're like, well, that doesn't look really fancy when I'm working with somebody and I can't use all those NDT techniques that I learned, and I'm not doing all this stuff. And so all that stuff that we learned, whether that be modalities, NDT, different interventions, Feldenkrais, whatever it is that you're into, those are all adjuncts to work on function. And if you don't follow that stuff up with function, and function isn't totally intertwined into your treatments at enough frequency and intensity, then we're not going to improve in those areas as we could. So that's how you measure yourself, always coming back to the original test, always measuring it against what norms are, where they fall in those norms, have they met meaningful change? If they haven't, what can you change? If they have, way to go, write it down, document it, brag about it, move on. Talk about where they fall in the functional scale. Use the tools that are out there. All right, so I'm going to go ahead and stop the recording.